So PEA does not work like the rest of the mediators of inflammation. Does not increase with inflammation. It decreases with inflammation. That's a very, very important thing. This is in healthy tissue, a lot of PEA. In inflammation and in painful states, look, PEA is much less. I told you that, right? Why? Well, because the enzyme that makes it, NAPLD, goes down. The expression of this enzyme, we say the transcription, is downregulated. And the expression of the enzyme that makes, that destroys PEA, making palmitic acid, is increased. So it's a double whammy. The less production, more degradation, less PEA. So who cares? We do. We should care. Because if inflammation and tissue damage lower PEA production, then by replacing the PEA that we have lost in inflammation, we will have an analgesic and anti-inflammatory effect. So administration of exogenous PEA can offset this deficit. So we are giving a vitamin to a tissue that suffers from hypovitaminosis. That is a very important concept. It's not the same thing as giving a drug. It's restoring a normal level of an endogenous anti-inflammatory agent, an analgesic agent. So does it really work in humans? I only show you data from rats, mice, and stuff like that. It does. PEA, they concluded, may be a useful treatment for pain and is generally well tolerated. That's a very important initial clinical support of the idea that PEA is an endogenous analgesic and anti-inflammatory compound. Now, of course, the authors also conclude that more studies are needed, and that's clearly always the case. So acute inflammation is the type of inflammation which we have whenever our body is subjected to some kind of harmful stimulus, for example, a frostbite, for example, a cut. A little infection causes inflammation. It's a very protective response. We need inflammation. If we did not have an inflammation, we would die. That is acute inflammation, and usually acute inflammation is rarely treated, pharmacologically treated. I mean, if you have an allergic reaction, maybe you take an antihistamine, but in most cases for these things, unless they're very, very serious, you don't really go for a full treatment. I mean, maybe certainly an infection you do, but you typically don't treat the inflammation. For example, for an infection, you treat the infection, right? You take an antibiotic. You don't try and block the inflammation, because the inflammation is a response to the arrival of the bacteria, right? So this is something that also can happen in a lot of normal situations that are not really pathological. Venkatesh was referring before to what happens when you run, if you're an athlete and you run or you exert your muscles excessively, then you have lactate, myoglobin release. Those are all things that occur normally. They're not considered diseases. They're not pathological. Still, they can be harmful, right? Hurtful. So that's acute inflammation and is very useful in survival. What about chronic inflammation? This is where scientists are baffled. We do not know how an acute inflammation transforms itself into a chronic inflammatory condition where there is no more reason for the body to be inflamed. There is no more reason for that. There are no bacteria, there are no viruses. Is just a process that is self-generating, self-regenerating process. And it's at the basis of almost every important disorder that we have. Cardiovascular disease, rheumatoid arthritis, autoimmune disease, Alzheimer's disease and Parkinson's disease. These are huge conditions. And of course, cancer. So chronic inflammation is, I think Time magazine once called it, the silent killer. Now, what does PEA do in this context? Well, what we know is that PEA, particularly in chronic inflammatory conditions, and this has been shown in human tissue, is lower, just like I told you. The enzyme that makes it goes down, the enzyme that destroys it goes up, PEA levels drop. In allergic reactions, rheumatoid arthritis, and neurological diseases. And of course, we need more data, we need more conditions, we need to understand this better, but this is where we are right now. So if this is the case, what this suggests is that, of course, if therapeutic agents that for chronic inflammation should find ways of raising the levels of PEA, for example, PEA itself, or agents that raise it through some other mechanism. For example, my lab is interested in developing inhibitors for the enzyme that destroys PEA, and those inhibitors are very good at increasing the levels of PEA. But this is a drug. What about instead healthy living? And that's where I think my colleagues at Levagen with Levagen and Ginkor come into play. What they're asking is the question is whether in conditions that are not yet pathological, PEA could be also effective. And they've just shown some very convincing data that this might be the case. So I will stop this by saying that, of course, we need more studies, because this is despite the fact that 50 years, PEA was discovered more than 70 years ago, actually no, more, about 60 years ago in 57, we still need to understand in greater detail how it works in healthy people as well as in people with chronic inflammation or with chronic pain. But the data we have so far are really encouraging. So I'd like to stop here and just as a disclosure say that my studies are supported by the National Institutes of Health and by the Department of Defense by and large. We also received a generous gift from Ginkor, and I'll stop here and take any questions if we have time. I think we do have.